Welcome to our presentation. So we're going to be talking about a project where we were mapping alternatives to standard inpatient care. So my name is Jessica Griffiths, and I've been leading on this project with my colleague Helen Baldwin, who's presenting with me. And we also wanted to credit everyone else who's been part of the project. You can see listed on this slide. So this included other researchers at the PRU, external experts, as well as lived experience researchers.
Thanks, Jess. So this project was requested by NHS England with the key aim of mapping out any existing alternatives to standard inpatient mental health care, both nationally and internationally, and across all age groups. And in order to define services which offered something substantially different to standard inpatient mental health care, we applied a set of inclusion criteria which were based upon a previous manuscript developed by Sonia Johnson and some colleagues. And so we defined alternatives as those aiming to serve people who would otherwise be admitted to an acute psychiatric ward or to receive long-term inpatient psychiatric care, as well as meeting at least one of the following criteria. So alternatives had to be either based outside of a hospital setting, dedicated to a specific diagnostic or socio-demographic group, had a fixed maximum length of stay, had implemented a specific therapeutic model which involved change in the practice of more than one profession, or involved different types of workers in care, such as peer support workers, or those services which featured a significant change in the practice of management of risk. And in order to address this question, we use two different sort of research work streams. So the first being literature searching, where we conducted some searches within both academic databases and grey literature to identify relevant academic and grey lit. And then an expert consultation phase where we reached out to people who may have had expertise in the area, and this could include healthcare professionals, academics, lived experience experts, policymakers. And we reached out with a call for evidence to see if they had any knowledge of services which might meet this criteria or any applicable evidence which we could sift through.
So in terms of outputs, so we produced 3 different maps, which I'll talk you through, along with a database which had further information about each model. And we're also planning to write it up as a manuscript to publish. In terms of the maps, so we produced one map for alternatives to acute inpatient care for adults and older adults. We had one for alternatives to long-term inpatient care for adults and older adults. And we had a map for alternatives for children and young people. And on the right, we have a key, which shows that on the maps, any green text indicates models primarily focused on assessment or signposting. A grey border indicates models which were picked up from grey literature. The world symbol indicates models that are international only, so not based in the UK. And the scale symbol indicates forensic models on the children and young people map. So I don't have time to show you all of the maps in detail, but I wanted to be able to give you a bit of a demonstration. So I will switch screens. So here we have our map, which shows alternatives to acute standard inpatient care for adults and older adults. And so if I zoom out all the way, you can see that it's big. We managed to pick up a lot of alternatives. And as I zoom in, you can see that it's separated out into 3 branches. So first of all, we've got community-based services. Then we've got hospital-linked alternatives. And finally, cross-setting approaches. So as we scroll back up to our community-based services, you can see that here is where we've picked up some residential alternatives, such as crisis houses and their various subtypes. We've got crisis team beds, as well as family placement schemes, where someone might spend a period of time with a host family or carer during a crisis. We've got acute day services, such as general and specialist acute day units. And we've also got some home-based crisis services. So here we've got our crisis resolution and home treatment teams and other similar models. This branch here, emergency service linked models, includes police and ambulance street triage teams who go out and respond to crises in the community, as well as health-based places of safety. Here we've got some drop-in crisis services. So this includes things such as crisis assessment services, crisis hubs and crisis cafes, as well as remote digital crisis services, such as telephone helplines, including peer-led ones. This next branch, discharge transition support. So this picks up models which are really focused on supporting that transition from inpatient care back out into the community. And we also picked up some outpatient-based crisis services, which provide sort of short-term outpatient support to people in crisis. And we've also got this branch, which is general community services with crisis functions. So these provide sort of secondary care more generally, but they can also provide stepped-up care during a crisis. So here we've got enhanced case management models, such as assertive community treatment or peer-delivered case management. We've got enhanced community mental health teams, as well as a couple of early intervention models, including early intervention in psychosis services. And as we scroll down to look at our hospital-linked alternatives, so first of all, we've got some models involving general hospital medical care, such as various psychiatric liaison models. And we've also got these brief admissions to general medical wards with specialist input from community eating disorder teams. These brief stay crisis units all do similar things, and the idea is someone stays there from anywhere between a few hours to a few days, and their aim is to stabilise the crisis and avoid a need for an inpatient admission. And we also captured some inpatient models that are doing something substantially different to the standard. So this includes services implementing a specific therapeutic model, safe wards being quite a widely known one, and also inpatient services specialised for different groups, such as for deaf people or people with a particular psychiatric diagnosis. And we've also got short stay acute inpatient wards where there might be a short maximum length of stay, for example, up to a week, rather than allowing sort of more extended admissions. And then finally, we have our final branch, cross-setting approaches. So these aren't so much implemented in one specific setting. They're more kind of approaches to care that can be applied across multiple settings. So here we've got things such as open dialogue, therapeutic communities, the sanctuary model, which is a model of trauma-informed care, as well as some whole system models as well, such as Trieste in Italy and the Buurtzorg model from the Netherlands. So that gives you a bit of an overview of our adult map. And just to give you a snapshot of our map of alternatives for children and young people. So here is that map. As I scroll out again, you see it's large. We picked up lots of alternatives, but again, it follows that same basic structure of community-based services, hospital-linked alternatives, and cross-setting approaches. And as you take a more detailed look at this map, you'll see that actually there is quite a bit of an overlap with the models that we picked up on the adult map, with a lot of them sort of catering to children and young people in their adolescent years. Although there were some models specifically developed for children and young people, some examples being therapeutic foster care as an example, or the home builders model, which is a home-based crisis service. Or as we scroll down to hospital-linked alternatives, you can see that there are some wards specifically for children under the age of 13. And what we noticed about these approaches for children and young people is that there tended to be a bit more kind of a systemic focus, so an emphasis on involving networks such as the family, school, social care, and other involved professionals. And now I will just hand back to Helen to talk through some more of the key findings.
Thank you. So as you can see from the maps that Jessica demonstrated, we did identify a very wide range of hospital-based alternatives and community-based alternatives. And whilst we didn't comprehensively map the geography of all of these different alternatives, we did notice that there appeared to be quite considerable geographical variation in the available support. So, for example, in the UK, a lot of these alternatives tend to be clustered in the south of the country. Whilst we did try and pick up common exclusion criteria, this was quite patchy across the different services. But where this was available, we sort of tallied some of the most common exclusion criteria, and compulsory detention under the Mental Health Act, or another country's equivalent, was the highest reported exclusion criteria for these services, followed by a person being at high risk either to themselves or to others, and drug and alcohol use difficulties, which I think really starts to question, if these large groups are being excluded from these alternatives, to what extent do they truly offer an alternative to standard inpatient mental health care? We also identified a general lack of provision for younger children, as well as for young people who are of that age where they're transitioning between childhood and adult services. And whilst we did list these different types of formal support, it's also important to highlight, I think, the importance of informal support from people's social networks, so from their family, their friends and their partners, but there often being a lack of support for those people. And there's a few key implications, I think, leading on from this work. So we hope that these sorts of typologies can be helpful in informing service planning, service delivery and policy making, as well as guiding research and evaluation efforts for models which have received less funding and less attention overall. So in line with that, there were a lot of models offered by the voluntary sector, which tended to have sort of less literature and less research applied to them. So I think it's important to highlight the contributions from the voluntary sector, but note that sometimes these organisations have fewer resources to undertake such rigorous evaluations needed to prove their efficacy and effectiveness in practice. And on that note, I think future research really needs to reflect the priorities of service users and carers, and in particular, investigate what works best for whom, when, and how. And so if you do have any further questions, we're hoping to submit a manuscript for publication relatively soon, so keep an eye out for that. But if you have any questions in the meantime, the contact details for Jessica and myself are listed here. Please do feel free to reach out with any questions or feedback. We'd be happy to hear from you.